Okay.
Yeah. So, as I was saying, it is a tremendous privilege actually to be given this opportunity to talk, given this opportunity by my esteemed seniors and and the office bearers of IMA, of IPS, Kerala as well as South Zone, and also my dear friend Namitha ma'am. So, without further delay, let me start with the topic for today. So this commit to quit, indeed, it's a catchy slogan, and it's not my brain. It is the WHO's motto for this year: commit to quit for the World No Tobacco Day 2021. So the question is, as a healthcare professional, what is our role? So it is my personal opinion that we serve many roles. Sometimes we serve as the coaches. We are going step by step with them. We encourage certain things, we discourage certain things. And we also have to be cheerleaders. So when there are small successes, small achievements, we should definitely acknowledge that. And finally, the end goal of both the patient and us is that they are in a position where they can quit this dangerous habit. So, yeah, sorry. Yeah. Now, the funny thing is, or rather, the irony is that we get a lot of messages from those in society who are responsible for dealing with our health problems. So, WHO has said last year itself the secret is out. What is the secret? That the tobacco industry kills about 8 million of its customers each year. And so that is why they are aggressively targeting the newer generations, the adults and adolescents. So, tobacco eats us up from inside. Tobacco makes us infertile. Tobacco gives us heart attacks, destroys our lungs. So, we are told time and again by many of these bodies that tobacco is a killer, tobacco is a villain. Whereas on the other side, there are those who are responsible for leading the tobacco industry, for making sure that tobacco is a profitable business for themselves, of course, and also sometimes for those we choose to be governing us. So those who are governing us are sometimes caught in between two pulls. One is that a major source of revenue, which they are sometimes unwilling to cut off, and on the other side, they are also they have the task of ensuring the health of people whom which has been entrusted to them. So it is no surprise that those who are novices into free society, are children, the adolescents, the young adults, they are in fact confused. And it is no wonder actually that they're in fact drawn to the shinier side, the more glamorous side, the side that tells you that tobacco use is something that shows your class, your style. So that is a problem that we are facing. So just to give you an outline, today's talk will be divided into three sections. One is where we will just briefly touch upon the biology of nicotine addiction and the biology and other factors involved in relapse. The second part will be what I would like all clinicians here, and indeed if there are members of the general public, to focus on, because this is some information that I thought, or I have seen, what I have seen in these years of practicing with patients, that these questions often come up in our discussions. And then we have the third part, where I think, just like Dr. Radhakrishnan sir, he had mentioned the newer devices, because the older practitioners, or maybe those of us who are not concentrated in the urban areas, we might not be familiar with these newer devices that are coming up. And of course, how can you not, or how can you end a topic without talking about COVID 19? So, tobacco and COVID 19. This will be the outline of the talk. So, starting with the first section, whenever we talk about substance use disorders, especially psychiatrists, we say tobacco, alcohol, and other drugs. Now, that is not, of course, because tobacco is not a drug or nicotine is not a drug. It is because somehow it is thought of as a very non problematic substance. It is not going to make you intoxicated. It is not going to change your behavior in any negative way. In fact, some people claim that they function better with tobacco. So it might surprise us, or some of us at least, to know that when you compare the addictive properties, tobacco is in fact on top of the list. In fact, on top of the substances we consider illicit, like heroin as well as cocaine. And why does this happen? So why this happens is because
A minute.
tobacco actually works upon the nicotinic acetylcholinergic receptors in the
Dr.
brain.
Aishwariya,
Yes, yes, ma'am.
um, sorry, I forgot to invite Dr. Kiran to chair the session.
Oh,
So,
good to know.
Kiran sir,
No problem, no problem, ma'am.
sorry, I just
Carry
missed
on.
a word. Okay, sir. So, Dr. Kiran, consultant psychiatrist of District Hospital Kollam, will be chairing the session. So, I think you may continue and discussions. Sir, lead. Sorry for the mistake.
Dr. Aishwariya, you can carry on.
Yeah, thank you, sir. So I was saying that nicotine, although like nicotine is something like a magic drug, whereas the other substances, let's say heroin, acts on the opioid receptors, or cocaine acts in other ways. But nicotine is the type of drug that results in release of a number of neurotransmitters. So that leads to the funny actions that sometimes nicotine calms us down, and sometimes nicotine, in fact, leads to more arousal, more speed of processing, and more activation. But however, the key action of nicotine that leads to its addictive property is just like Sir had already mentioned, that nicotine releases dopamine in our reward pathway. Simply put, the brain has a specific circuit that processes those stimuli that are pleasurable to us. So that includes a lot of natural things like food or water or sex, and that also includes a number of substances that are not naturally meant to be used as rewarding things like substance use. So in this reward pathway, nicotine releases dopamine. So that is what happens when you're using nicotine for the first time, or maybe a single use. What happens when you use nicotine repeatedly? So, what happens when you use nicotine repeatedly is that it actually inhibits the enzymes that are meant to break down certain neurotransmitters, which means that these neurotransmitters will be present in an excess. So, if they are present in an excess in the brain, they have certain properties or certain effects that are attributed to them, like the arousal properties. Okay. So, on chronic use, the actions are a little different. Now, the more problematic issue is what happens when you stop chronic use. So, that is where you see in this fourth point in the diagram that there is a drop in the dopamine use. So, somebody who has been used to a burst of dopamine coming multiple times in the day whenever they are smoking, all of a sudden they are left with normal levels of dopamine. And these normal levels of dopamine are perceived by people as being insufficient. And a person who would have naturally or normally would have felt pretty normal with that level of dopamine, when he is used to excess dopamine in the system and all of a sudden it is taken away, it is experienced as a lack of dopamine. So that is what later on I'll be talking about, is the hedonic dysregulation. So so when somebody is chronically using nicotine and suddenly stops, and there is a host of uncomfortable symptoms, like what? Like anxiety, like depression, like restlessness, like problems with concentration, constipation, which many patients come up with, lightheadedness. All of these problems tend to come up in the first 1 month uh, of stopping nicotine use, and some of them last for even longer than 1 month. And generally, we say within about 2 to 3 months, most of the withdrawal symptoms, they wear off. But cravings can even last longer than that, which is a psychological symptom. Now, yeah, so keep that information in mind because we will be using that later on when we want to talk about relapse prevention. So, this slide also mentions hedonic dysregulation, which is that an amount of dopamine, which would be normal for any normal individual, non addicted individual, is perceived as too less dopamine for somebody who was dependent on nicotine and suddenly stops using tobacco. So let's just keep this in mind. I mean, the prevalence of these withdrawal symptoms is quite high, right? So up to 60 to 70% of people will face one or the other things. And most of these symptoms will be They are over a course of weeks. They can last up to 1 month. And that is why our support is crucial during this period of time. So I know biological basis, some of us might not be very interested in it, but let me just give a very simple explanation. So the nicotinic acetylcholinergic receptors, they exist in three forms. So the first is the activated form, when nicotine binds to the receptor and it is, leading to the host of actions it usually has. When when nicotine is bound to the receptor for a prolonged period of time, for example, when somebody is, smoking in a pattern that's typical for dependence multiple times in the day, so that there is a near constant level of nicotine in the blood. In that condition, the receptors, they tend to exist in a desensitized state where nicotine is bound to the receptor, but however, they are not causing the actions to happen. Now, when somebody abstains from smoking in the day, for example, for a period of number of hours, or usually overnight, when somebody has gone to sleep, and then these desensitized receptors, the nicotine will disbind from the receptor, and they will go back to their normal unactivated resting state. So, when they are in this position where they have recovered their sensitivity, and there is a lot of these nicotine receptors just waiting for nicotine, this is perceived as a very uncomfortable situation by the patient. And this is the reason why generally we use that quality, that morning, as soon as you wake up in the morning, within how many minutes do you need to take your first smoke? So that is one of the articles, one of the items that are present on the Fagerstrom tobacco nicotine tobacco dependence scale. So on that, we see that within 5 minutes, or about 5 to 10 minutes, or more than 10 minutes later. So the fact is, it is an indicator of the severity of your tobacco dependence. When you wake up in the morning, that is several hours after you have your last smoke, how terrible do you feel, or how strong is your craving to take the to take the first smoke of the day? So that is the biological basis. Now let us look at the psychological basis. So for the purpose of that, let us all, in fact, pay respect to this one of the most famous dogs in dog history, that is Pavlov's dog. He might have had many dogs, I'm not sure, but now this particular dog, uh, he made a lot of sacrifices for us because he was really frustrated a number of times. Let me just put this very simply for non-psychiatrists. This is the process of learning that is called classical conditioning. Okay, so in this circumstance, imagine that a dog is offered food. So, or even if a human being is offered food, so salivation is a very natural reflex. So, a natural reflex which does not require any training previously is called an unconditioned reflex. Now, in this circumstance, suppose you are ringing a bell in the background, there is no food, you're randomly ringing a bell around the dog. The bell doesn't mean anything to the dog. So, there will be no salivation, no response whatsoever. But suppose you train the dog that if you ring the bell, that means food is available in the next 1 or 2 minutes. So it was seen that when repeatedly you perform this, you ring the bell, present the food, ring the bell, present the food. It is seen that on ringing the bell itself, the dog's salivation response begins. So the reflex has actually been learned by that point of time, so that finally when you just ring the bell, the dog starts salivating whether you present food or not. Now there is a lot of the experiment goes on to show that once you have learned this response, how do you unlearn this response? Okay, but this is the basis for many of our relapse prevention discussions. Why? Because the very same procedure or the very same process acts when somebody is taking drugs. So if of those of us who don't smoke regularly or who don't use tobacco, if we see packets and packets of cigarettes lying around, it means literally nothing to us. But if a person who has been a smoker or is a current smoker, and he sees a number of packets of tobacco piled up, it is guaranteed to elicit a lot of craving in that person. So that is the power of conditioning. the person will be conditioned to these kind of cues that will remind him. So any friend of his who used to smoke along with him, any place where he generally takes a smoking break, like the not the cafeteria, but maybe he goes outside, like outside in the workplace to take a smoking break. All of those become powerful cues, and they're everywhere because smoking is not prohibited. You can very well, smoke unless it's a public place where other people are gathered. You can smoke anywhere, and nobody looks at you like it's a crime. So, because of that, these smoking cues are present everywhere, and we have to be aware that that is why it becomes a very big struggle for those who are interested in quitting smoking. Yeah. So as I said, so these changes, there are biological changes that are taking place. There are these psychological learning that has been acquired over, years and years of smoking and associating smoking with hunger, with tiredness, with sleepiness, with, wanting to stay awake, with depression, with anxiety. So smoking has been associated with multiple moods, multiple cues, and that is why we need to use a combination of both pharmacological and non pharmacological treatment when we are dealing with tobacco dependence and when we are helping people to quit. Yeah. Another concept that I would like to leave you with is that when you talk about relapse, most of us think of it as okay. I mean, even not just smoking, but even when we talk about alcohol, that yeah, this person was abstinent for about 3 months and then he relapsed, last week. So the point is, relapse does not occur at the time when the substance is consumed after a period of abstinence. There are some distal factors like what? The person is, generally stressed in life. So that provides a very fertile condition for him to relapse to smoking. Or he experiences urges and cravings off and on once he has decided to quit. Or he has made the decision to quit, but he knows that he has a couple of packets stashed away somewhere that that maybe he is kept for some days when he might feel a very strong urge. So that is called an apparently irrelevant decision. All these factors, they will work in the background, leading to him confronting a high risk situation. For example, on a day when he has been yelled at by his boss at the workplace, that day he is extra stressed. And then he comes home, he remembers, I have this packet of cigarettes to fall back on to relax. And so he goes and smokes. And then that then becomes the episode of lapse. There are also a few other things which I'll be covering in the thing. So, anyway, the concept that I'm trying to put across is that when you're thinking of relapse, don't think about what was that one day's instance that happened when the person relapsed. Look at it as, is the person in general having a lot of lifestyle factors that predisposes him throughout to relapse? Is there a lot of urges that he's constantly suppressing and trying to get over? Is his way of thinking about smoking and quitting smoking faulty? So I'll also talk about this in the coming slides. So that is why when you talk about behavioral interventions, which may be like a step beyond what general practitioners will be willing to offer, maybe like psychiatrists or addiction professional. So in that case, what we do is we try to pick up the high risk situations. So for every individual, it will be different. For a doctor, it might be a lot of fatigue. For a laborer, it might be a time when he's experiencing body aches after he comes home from work and he's not able to go to sleep quickly. So these high risk situations differ for everyone. Once we identify them, we equip this person with some coping skills. So if you face this situation, you have these 2 3 ways of coping with it. Some of it might be behavioral. For example, as you come home, if you're going to experience craving, just have a lot of, I mean, not a lot of food, but have your dinner so that the craving to smoke goes down a bit. Or maybe before you go to sleep, take a glass of hot water so that it helps you to fall asleep faster. Those are behavioral methods. Suppose there are cognitive methods. Suppose it is you're extra stressed at work and you tell yourself, yeah, I deserve a little break. I mean, what is this? If I can't even smoke a cigarette, then what am I alive for? So you change that thinking that smoking is not something that is, that is not going to change my stress in any way. In fact, if I fall sick tomorrow, that's just going to add to my stress. And then we also deal with the distal factors, the faraway factors. That is, what was the background stress in life? What is his habitual ways of thinking? How does he set himself up for relapses? So these are, like when you go into the depth of behavioral relapse prevention. So that by now I have just given you an idea of what is the biological basis, the psychological basis behind nicotine addiction, what are the kind of treatments we employ. We need both. We cannot just be aware of one part of it. And what are the the nitty gritties of the psychological interventions. Now let me just also, or let us just take a look at the size of the problem that we are up against. So I have only talked about the figures from Kerala because this is what is relevant to, those of us who work in Kerala and live in Kerala. Yeah. So what we are seeing is that there is some reason for us to be happy because the tobacco use is showing a declining trend over the past. The two studies that we have from the Global Adult Tobacco Survey, from where we know that the current prevalence stands at about 12.7% of the adults in India using tobacco related substances. Sorry, in Kerala. I'm sorry about that, and that is quite significantly less than the national average. And when we look at the type of the type of tobacco products that we are using, we stand in contrast to many of the states in India. Why? Because we prefer smoking tobacco. So 7.3% out of this 12.7 actually prefer smoking. There is a very small but significant percentage who actually use both, and these also will be coming across in your clinics. And then there is a smaller proportion that is using just the smokeless forms of tobacco. Some other important data. Okay, so the other thing is we have a cultural this one we have a cultural tendency to prefer betel quid. So many people also have some misconceptions about betel quid or murkan. So we have arecanut, we have the betel leaf, we also have some tobacco, and this can be used with or without tobacco, of course, but we are talking about the ones with tobacco. And another one that you will frequently come across is people mentioning the name Hans, which is just which is just tobacco leaves, which is referred to as gutka or other things in the rest of India. And however, smoke, as I've said previously, our preferred mode of use of tobacco is cigarettes, which is considered the most harmful form. Okay, now let us look at this age wise. So when we look at it age wise, what we see is that in the 15 to 24 age group, which is approximately the time when people are initiating, so there is an equal prevalence of use of smoking and smokeless. In the productive, the economically active age group, I'm not implying that those above 65 don't contribute, but anyway, what we consider the working population, they prefer cigarettes more. And towards the older side of the population, they stick around more with smokeless tobacco. So we just need to keep in mind that this is the kind of trends. This is what we can expect. And another factor is another important factor is out of this 12.7, 9.3% are daily users, meaning that they are significantly dependent. So if somebody says that they are using tobacco, more often than not, they are daily users and they are significantly dependent users. Now, those were some of the statistics which is interesting for those of us who want to study this behavior, like doctors or researchers. But what does it mean to the patient? How does it help him change his behavior? I'm not sure it really does. So, this time I thought that all these statistics, let us look at it from the angle of the patient. What is it that is relevant to him? And I have put together some questions or some statements that usually we come across. Number one, many old people smoke or use chewing tobacco. How come they don't have cancer? Implication that many people lead very fruitful, healthy old lives. Healthy lives till a very ripe old age, and they have been using throughout their lives, maybe from their early 20s. So why do we see this? Why do we see the data that you're going to die if you are a smoker or a non-smoker? So let us look at, so another important aspect that I will tell you is whenever we are employing psychological interventions, we always personalize the feedback. What is the relevance for this particular individual? It might not matter to him that in a community, these 10% will have this, or 30% something else might happen to them. What is my chance? So this is, some general facts that you can apply to any patient who is sitting in front of you and who uses tobacco. So if the question is, I am a smoker, what is the chance that I will get cancer? So I have put in between the scientific evidence based on which you can, give your responses. One response could be that compared to a person who does not smoke, you have an 8 times higher risk of suffering from only lung cancer. So this data I've taken from lung cancer because that's what everybody is used to hearing. Of course, if you count in the other cancers, the risk will be higher. Another favorite dialogue is even those who don't smoke get lung cancer. That's true. So you tell the patient, yes, there are cancers can be because of many reasons. Up to half the total number of cancers of any organ can be attributed to tobacco in India. For our knowledge, they're called the tobacco related cancers. So if you are a smoker, you have a 14% chance of developing lung cancer, which should be scary to any reasonable individual. The next question is, what is the leading cause of death due to tobacco? So the problem is that in everybody's mind, it is cancer, 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 because that is the scarier disease. That is a disease that results in all those malformations and all those painful treatments. But however, we know that ischemic heart disease is by far, or not by far, but ischemic heart disease is the number one cause of death due to smoking. So what you tell the patient is definitely cancer is among the leading causes of death, but the chances are that you will die from a heart attack more than that you will die from cancer because of tobacco. Now, is your lifespan cut short by tobacco? Just like Sir has already mentioned, yes, the answer is very simple. 8 to 10 years of life, or 10 to 11 years of life, up to 12 years of life can be lost because of tobacco. So you lose a decade of your life. You can personalize it even further. So maybe 60s to 70s, if you are going to naturally live up into your 70s, you're going to pass away in your 60s, by which time you might or might not have any grandchildren. So that is, just ways you can personalize it for patients. How many tobacco users die because of their tobacco use? So this question is very important because half of all smokers will die because of tobacco related illnesses, meaning tobacco will be the reason, or in 50% of, or you have a 50% chance that tobacco is going to kill you. And the remaining 50% is, of course, you might suffer an accident or something else, right? But tobacco takes over the majority. I can say the as a single this thing, it takes over 50% of the risk of causing death. So there might be several more questions they come up with, but in any circumstance, what I'd like you to remember is personalize the information to his individual situation, and then that message might strike harder. This is for our knowledge that when you look at the total proportion of ischemic heart disease, the deaths from tobacco might be like maybe about 1/5 approximately. You look at the total proportion of cancers, which is in numbers it is lesser, but in proportions it is definitely more. So majority of the cancers that you're seeing worldwide are as a result, or tobacco is a definitive causative factor for the same. Okay, the next question is, I tried quitting many times, but I'm unable to quit. I'm able to quit for a short time, but I start again. So what do you say for this? Again, like our respected president sir was saying, IPS president sir. So he was saying that you need to change your attitude. So as healthcare workers, we should know that relapse is in fact the rule. So if somebody has started to, who is making an effort to quit on their own, only 3% will be abstinent at the end of 6 months, unaided quit attempts. However, if they do seek help, then it is doubled, and in some cases, even approximately almost tripled at max, depending on what kind of help they get. Another interesting thing you can tell them is, on an average, everybody tries at least 4 times before they're able to get any permanent abstinence. And another important issue that we must be aware of, because our colleagues might refer patients to us. So 50% of people only quit even after suffering some major consequence like a heart attack or lung or laryngeal carcinomas. Okay. So suppose somebody is coming to you after facing this kind of a lapse. Generally, what we do is, okay, this would be a bit more in the realm of psychiatrists, but like once general practitioners are also familiar with these things, they're not really rocket science. So anybody can help them with these things. Just look at the lapse. What happened? What happened before the lapse? What were you thinking? So the permission giving beliefs. I'm really tired. I'm having a really tough time. COVID pandemic is, robbing me of my livelihood. I can at least smoke. So that's a permission giving belief. Any feeling that they anger or sadness. What was, did they face any high risk situations? They smelled smoke, while they were traveling in the bus. And that craving was, started from there, and they came home. They felt the urge to smoke and they knew that they had stashed away the cigarettes. So just ask them what happened before that lapse. What happened exactly? Give them advice specific for that situation. Then there might be other factors also. For example, that constantly they're having to fight with their urges, and then sometimes they just get tired of fighting those urges. So we analyze the lapse. If somebody comes with a relapse, we analyze the lapse. We normalize the fact that lapses happen. Everybody faces the lapses. So what is important is not that you think that, oh, now it's not worth it, I'm not never going to quit tobacco, I won't be able to do it. Don't look at things in such a negative manner. Look at it as a learning experience. Okay, so now I know that on the days when I'm particularly hungry, I've skipped my lunch at work, I have a tendency to go outside and take a smoking break. So now I know that I'll not skip my lunch. I'll take care of my meals and take care of myself. So don't be very hard on yourself. Just learn from it and don't let the same mistake happen again. So that was the abstinence violation effect that I was talking about. That one lapse means that everything is lost. The attitude of looking at things that way, which we really don't have to. Now, the other question, I cannot pass stools unless I smoke in the morning as soon as I get up. Then how is it possible for me to quit? So uh, that tells us that we should be familiar with the very common withdrawal symptoms that can occur as a result of stopping smoking. Some of the more problematic ones are oral ulcers, constipation, irritability, decrease in sleep, and other things. So we should know, there's a lot of literature on this. I don't think I can go into each and every withdrawal symptom exhaustively, and I'm sure like you would, those interested would definitely find resources on it. Let me just look at this constipation issue. So what we should know is constipation is a definite problem. That is what it is. First, our awareness. Now, how long does this last? It can last up to a month. So this person, our patient who is trying to quit, might actually be troubled to up to a month. Now, solution is so simple. We have laxatives. We can tell him that your lifestyle is changing. So take in a lot of water. Be sure you're a little active. Yes, and most importantly, that these symptoms are temporary. After a month, you're not going to face problems in this intensity. So, in addition to giving these simple things, simple solutions, it is also important that you give some reassurance that it is temporary. Withdrawal is time limited. The next question, I'm not addicted. I smoke just one cigarette a day. Can I continue? Or another question, I've stopped smoking. Now I only share puffs with my friends at times. So that's it. Yeah, my personal view is that it was a good step that was taken by by our government in banning the sale of any of these electronic nicotine delivery devices. Now we know that banning does not mean that it is not illicitly available. It is very much available. I mean, like many people already had these devices when they had gone to when they had gone outside our country and they'd already purchased it. So there are many interesting, many useful information piece, like information documents that have put together all the information from what are the harms that can happen because of electronic nicotine delivery devices. So some of the key things that we need to remember is that these things do contain nicotine. So if a non-smoker is going to start with nicotine use, it is very likely, and in fact it has already been seen, that adolescents, they do start smoking once they have started with the use of once they've used it, once they've started the use of these e-cigarettes or ENDs. The other problem is these things are also being used for non-tobacco or non-nicotinic products as well. Like what? Like cannabis solutions, cannabinoid containing solutions. So that is another problem. These solutions that contain nicotine also have cancer causing chemicals. Now, it has been shown that yes, they are less harmful than cigarettes, or they have a lesser proportion concentration of these toxins, but that does not mean that it is safe. Another issue is many of these things, these devices, they look like everyday objects. So they might be present in the schools. They might be, they can be very easily carried around, the pods for the cigarettes. And in fact, even parents, if they are not familiar with this kind of thing, they might go totally undetected. The other problem is that they are flavored in n number of chocolate, vanilla, bubblegum flavors that makes it very attractive to the younger, generation. So this is the problem. So it is an unsafe product, less harmful than cigarettes, admittedly, but posing a host of other problems. And we really have not had enough time to study what is the effect of these products on, longitudinally cancers and other issues. Yeah. So that brings me to the end of my talk. I hope that was useful. Thank you, and maybe you can take.
Thank you, Dr. Aishwariya, for this wonderful, exhaustive presentation, and definitely the thanks go to office bearers of Ima Desinganad, especially Dr. Namitha. And I think more than 10 psychiatrists attended the meeting, including our President of Kerala Psychiatric Society, Dr. Thomas sir, and past General Secretary Priyadarsini sir, and senior KPS leaders like Alfred sir. Many senior psychiatrists were there, and Dr. Shyam sir, actually it was my duty to introduce Dr. Aishwariya initially. Anyway, I would like to introduce her once again. She's now psychiatrist. This psychiatry have many super specialties like geriatric psychiatry, forensic psychiatry, addiction psychiatry, etc. And she's the, I think she's the only addiction psychiatrist in Kerala. Now she works as assistant professor at Malabar Medical College, Calicut. She is married to Dr. Ragesh. He is a hemato-oncologist at Maitra Hospital, Calicut. Thanks again, Dr. Aishwariya, for the wonderful presentation. And now the topic is open for discussion. She has addressed almost all questions and apprehensions of patients and doctors about tobacco use and cessation of tobacco. I think Thomas sir has some question to raise. Sir, unmute your mic.
Okay, am I audible now?
Yeah.
Yes, sir.
Yeah. Very nice presentation, Dr. Aishwariya. I was in between, I had some phone call and I had to go. Did you mention, or I don't know whether you covered it, the relationship with mental illness? Most of the time we go with the heart disease, lung disease. So some patients, mentally ill patients during the depressive phase, they start smoking. or during the manic phase, or it is a vicious cycle. This nicotine use can precipitate mental illness or perpetuate mental illness, or the vice versa also. Those who are when during the onset or due to their mental illness, they may start it.
Sir, unmute your mic.
Am I audible now?
Yes, sir. Yes, sir.
Yeah. Nicotine addiction or nicotine use has a relationship with mental illness. Sometimes it may precipitate, or the patient may use it during the phase of depression, during the manic phase, like that. Can you just highlight that, Dr. Aishwariya, so that general practitioners will be more useful? At least, or don't think all these things are only because of addiction. Think in terms of some mental illness, maybe a marker for to just identify some of the mental illness like that. That you have to keep in mind when you are dealing with all these things. And another thing is, Dr. Aishwariya has mentioned about these digital health workers. Now it is becoming more important. Western countries are even very important. And I think during this era of COVID time, we have to practice those who are interested in it. So can you just highlight the relationship between the mental illness as well as smoking or any nicotine use or any?
Yes, sir. Thank you so much for reminding me about that very important aspect. So yeah, so as we know, like these those with mental illnesses, especially the severe mental illnesses like schizophrenia, other psychosis, those with mood disorders, including bipolar illness as well as depression. So all of these people have a higher prevalence of smoking compared to the general population. There are many theories also behind it, and in illnesses like schizophrenia, it can reach up to 90%. 70 to 90% of these individuals actually suffer from smoking. And what we generally understand is that schizophrenia does not kill the patients. It is the MI, or sorry, it is the cardiovascular illnesses and the cerebrovascular illnesses that actually result in the death of our psychiatric patients. And it cuts down their lifespan by 10 to 20 years because of schizophrenia, as well as these associated problems. So one thing that general practitioners can be alert to is that if your patient is reporting significant anxiety or depressive symptoms during the time when they are quitting. So it is quite uncommon that anybody will suffer the first major depressive episode of clinical depression once they quit. What is more likely is that the person already has a history of mental illness, and the period of tobacco cessation has been seen to precipitate these mental illnesses. So, those with anxiety disorders and depression, most of them might be untreated when they come to you in practice. Kindly do refer them to a psychiatrist for the due treatment that is required for that, because a person with anxiety disorders and depression, they will be facing additional problems when they have to quit nicotine, which might not be within the purview of a general practitioner. So definitely, like, refer the patient to a colleague, or like, be familiar with the symptoms so that you're able to identify those. Also, the same goes for cardiologists and neurologists. So post stroke depressions, post MI depressions, deliriums, these are also conditions which these practitioners in other specialties will have to see. And that is also a very big window of opportunity. If the patient has just suffered an MI, that is a very good window of opportunity for us to address tobacco cessation. So do involve colleagues, or you can definitely do it on your own. Thank you, sir, for reminding me about that aspect.
Dr. Aishwariya, it was an excellent presentation. You have covered almost all the area concerning the tobacco addiction. And my question is, we see many patients smoke more during the exacerbation of psychotic symptoms, that is delusion and hallucination. When the symptoms are exacerbated, we see the smoking is more. And how do you explain that? And another question is, tobacco use, does tobacco use, increased tobacco use, decrease the efficiency of our drugs.
Yes,
The
sir.
second question is, increased tobacco use decrease the efficiency of antipsychotic drugs.
Yes. So yes, sir. I'm glad you brought that up, because for our psychiatric community, that is very important, in fact, to know. So link between tobacco and schizophrenia has, of course, been studied. Why is it that during psychotic breaks, the smoking tends to increase? So there are many hypotheses behind it. Not one is supported. One can be that the smoking helps to it sort of fixes that sensory gating, so that the tendency to suffer from hallucinations will decrease. So people actually smoke to self-medicate the symptoms of schizophrenia. The second theory that has been put forward is sometimes the negative symptoms of schizophrenia. So the alertness, the arousal that comes from smoking tobacco might help them with the negative symptoms, the negative psychotic symptoms. So that could be the reason why during psychotic breaks, people tend to smoke more. The second question you were, whether smoking influences our drugs. So absolutely, because of the cytochrome enzymes, they get induced, enzyme induction, and which then influences the level of the drugs. So many of our antipsychotic drugs, the levels of these antipsychotics are brought down by concurrent tobacco smoking, especially clozapine, one of our favorite weapons. So that is the relevance. So if your patient is smoking a pack or more of cigarettes a day, and you're you might have to actually go beyond the therapeutic, the optimum range, which exposes them to more side effects, at the same time lesser efficacy of the medicines. So few aspects we can keep in mind.
Thank you.
Dr. Aishwariya. Dr. Aishwariya, I would like to ask, it's a common situation which many people face. Like we see that maybe in our family someone is smoking, and we ask them to quit, but they are in total denial that they have a addiction issue. So despite psychoeducating and all that, they are still in denial. So how do we break that denial? Thank you.
Yeah. So I actually did not go into the details of that thing. So I had mentioned somewhere that when you are when you're addressing tobacco cessation with somebody, the patient might be at different stages of motivation. So what ma'am is saying is that the patient is in pre-contemplation phase, where they're not even accepting that there is any problem, and they're not accepting that there is any need for changing this behavior. So then you enter into a conversation. So that is where the 5 R's model comes into play. So what you do is you discuss the decision with them. I mean, you discuss the situation with them. You explore the risks of quitting. So you're telling me that you're not addicted. So what do you lose by stopping for 1 week? That is how you tell them to get the risks. What is the problem if they stop? What is the rewards of continuing with this behavior? So suppose you smoke once a day at night. You told me once a day at night. What do you get from that? Then you look at what are the roadblocks. What is it that you're afraid of? Suppose you give up smoking for a month or a week. What are you worried about? Or maybe 3 days. Suppose you don't smoke at all. What do you lose? So that is like roadblocks. So you address in this way, and the aim is that, and then you repeat. So it might be that the first 2-3 times, or maybe 10 times, patient is really not willing to you, or maybe he's just not in that frame of mind to even listen to you at all. But when you repeat the same advice over time, the person is convinced that you're coming from a point where you're a well-wisher, then he will definitely consider, and the hope is that you can just push him along in motivation. From pre-contemplation, he might contemplate few more conversations. He might actually think of forming an action plan about it, prepare to quit, and at the end we might actually succeed. It depends, but this is what we can do.
Thank you, Doctor.
Dr. Aishwariya, I have seen 2-3 cases of addiction to nicotine gums. Have you come across such cases?
Yeah,
and what you
Yes, sir. So that is another question that I have been asked. So will I quit smoking and then become addicted to Nicotex or nicotine patches or the medicines that you're giving me? So another question is whether this person is started using Nicotex and Nicotex is the only product he's using. Is that the scenario, or is it that he was a smoker and then he shifted to nicotine? Nicotex. Anyway, let's think of it two ways. So suppose this patient has been not using any tobacco product and they started with the use of nicotine gums. So that is actually a misuse. We'll consider it like, an abuse of pain medication. So pain medications are for pain. But if you start abusing them for their euphorogenic potential, that is an abuse of the drug. Similarly, if the person has used only nicotine gums in his life, and now he's addicted to them, very possible, because nicotine is, as I said, very strongly addictive, or the addictive potential is very high. So if that is the way it is, we will deal with it like any nicotine or tobacco addiction. We will give him the many behavioral as well as pharmacological interventions. Suppose the question is otherwise, that I am a smoker, you are putting me on nicotine gums. Will I become addicted to nicotine gums? So the rationale behind it is, you are already a person who is dependent on nicotine. You are only shifting from a form that gives you 7,000 toxins, in which at least 70 or 200 of them are cancer causing, to a product that gives you nicotine that you're already addicted to without these 7,000 toxins. So right now, we are only shifting you to a less and a much less harmful form. And nicotine is not meant to be used beyond 6 months, although studies show that it is used up to 52 weeks without causing any significant problems. Beyond that, I'm not aware that there have been any larger or many studies beyond 1 year. But up to 1 year, you can definitely use it. And the point is, you will taper it down so that instead of facing, a cyclone of withdrawal symptoms, it'll be like a mild monsoon. So that is the whole point. So we'll explain it in that way. And yeah, many people have asked this question, frankly. Thank you, sir.
Thank you.
There are no more
Dr.
questions.
Aishwariya, I'm Dr. Alfred.
Any questions?
My doubt is, many a times we find it more difficult to treat nicotine dependence than alcohol dependence. What is your experience?
Sir, the problem with that is, like, nicotine dependence, it causes a lot of harm to the individual. And harms to society are a little indirect in that it's not the person's behavior that is causing a problem to us. It is more like the health costs that we also will end up paying because we are tax paying citizens, and those are all indirect. You don't attribute those problems to the person as such. But with alcohol dependence, the person's behavior changes. So the psychosocial disturbance is so severe that how do we put it, like the quality of life of everyone who is involved in that person's family really decreases. That kind of thing is not seen. But getting people off nicotine or alcohol, I would say they're equally difficult, frankly. I mean, if it is only the addiction part we are taking into account more than the rest of the things, then both are equally difficult. Like, people, I have seen few people who have been who are able to abstain for some significant period of time. But of course, my experience is also very few years. So,
Dr. Aishwariya, will nicotine will reduce the bioavailability of the medicines which we give to the patient? Read somewhere.
yes, sir. So, because nicotine is a cytochrome inducer, so because of that, many of the drugs that we prescribe, their levels will follow below the therapeutic range. So that is a big problem that we face, which is why smoking, schizophrenia, and antipsychotic drugs, so the drug interactions that lead to many of us having to go beyond. So even for clozapine, as we usually see, the smokers, they need a higher dose. So higher dose, higher side effects. And we are not achieving the desired therapeutic effects.
Only for exclusively for psychotropic drugs or any antipsychotic medications or for general medicines also it may be possible.
Yeah, it may very well be possible, sir. Like I cannot comment on specific drugs, but definitely like those interactions are known.
There are no more questions. Can we wind up the session? Dr. Kiran?
Thanks our psychiatrists for making the very active. Any questions from non-psychiatrist doctors?
സൈക്കാട്രിസ്റ്റുകളുടെ ഏകദേശ കാര്യങ്ങളെല്ലാം തന്നെ ഡൗട്ട്സ് ആ ടോപ്പിക്കിൽ കവർ ചെയ്തിട്ടുണ്ടായിരുന്നു. ഇത് കോമൺലി ഫേസ് ചെയ്യുന്ന ക്വസ്റ്റ്യൻസ് എല്ലാം ക്വസ്റ്റ്യൻ ആൻസർ പോലെ തന്നെ ശരിക്കും ഐശ്വര്യ എക്സ്പ്ലെയിൻ ചെയ്യുന്നുണ്ട്.
ഒരു ചെറിയ ചോദ്യം ഉള്ളത് ഡോക്ടർ ഐശ്വര്യ, നമുക്ക് ഈ people do come as because we work in the ESI, we usually conduct general OPDs only. So people do come with requests like, I smoke a lot, so can I switch over to Vicotex and bring down my thing? Can we as general practitioners do that, or up to what time span can we taper it down as a general practitioner? Psychiatrist, okay, different scenario.
Yes, ma'am, totally. Because these nicotine replacement products, they're actually over the counter. So even without our advice, people can go and procure it. But the best part is, like as general practitioners, we can actually tell them the right way to use the product. So like maybe, like we might get another opportunity to talk about that, how each of these products is used. But as a general, this thing, or let's say nicotine gum or any of these NRT products, they will give you only 1/3 of the nicotine that's present in the number of cigarettes that you are consuming. So we are on the danger of underdosing. We will say take 2 gums, take 3 gums, which will really not help that smoker at all. So you give them an adequate dosage of the nicotine gums. We cannot prescribe that, okay, let's say 6 sticks of cigarette, that means that you take 6 gums. It is approximate, and you will always have to change according to the patient's response, because metabolism also varies from one person to another. But the just broad thing is that you can prescribe up to 15 gums in one day. Nicotine gums need to be prescribed on a regular schedule, not like SOS. So not that you take one the thing when you feel craving. You take it on a regular thing, because the point is that you don't experience craving at all. And then you cut down also in a very gradual this thing. Take at least 2 weeks for you to decrease the dose of gums. And the general principle is within 6 months, you would have tapered them off whatever nicotine replacement you have given. And general practitioners definitely can, because we have even dental practitioners prescribing these things in our tobacco cessation clinics.
Thank you.
Thank you all. Any more questions?
Yeah, during these COVID times, is it not the right time to motivate people to stop smoking? Because we have seen most thromboembolic events which cause mortality in COVID. So I think this is the best time to motivate people, isn't it?
Yeah, I completely agree with you, sir. Like now is the time when every person in OPD can be, in fact, targeted, told to quit smoking, especially when this data that you can tell them that, that you have a risk of severe disease. The more you smoke, the greater your risk of death and needing mechanical ventilation. So those realities, it is a perfect time, just like our president sir also said. Window of opportunity, we should use it. All of us, in fact, not just psychiatrists.
So shall we wind up the session, Kiran sir?
Yeah, sure.
Okay. Once again, apologize, sir, for not having invited you before the session. Very sorry, I somehow missed it. Anyways,
No, it was an excellent presentation by Dr. Aishwariya.
so thank you, sir, for chairing this session, as well as thank you, Dr. Aishwariya, for giving this wonderful session. It was a storm of knowledge, like, you brought forth so many points and they're so very relevant. So, and thanks for the audience for having a wonderful discussion also. So